There is a protocol taking the hormone space by storm on social media right now, and it has a lot of women talking. It involves using certain histamine blockers, often H1 and H2 blockers, to help relieve severe PMS, PMDD, anxiety, mood swings, insomnia, and symptoms that may be connected to histamine intolerance or mast cell activation. Now, I want to be very clear, this is not yet a standard, well-established PMDD treatment that you're going to find in every medical textbook. The research is still limited, but patient experience and clinical experience are showing something really interesting. For some women, especially those who have histamine type symptoms, these medications can bring significant relief. And if you have ever experienced true PMDD, you know this is not just being moody before your period. PMDD, or premenstrual dysphoric disorder, can feel like your brain and body are hijacked. Women describe intense anxiety, rage, depression, intrusive thoughts, insomnia, relationship conflict, and feeling like a completely different person in the days or weeks before their period. Then their period comes and they feel like themselves again. It is devastating, it is confusing, and for far too many women, it is dismissed. So today we're going deep into the connection between histamine, hormones, mast cells, GABA, progesterone, allopregnanolone, anxiety, and PMDD. And I could not think of a better person to have this conversation with than one of my absolute favorite guests of all time, Dr. Liz Bartman. I will link our first interview in the show notes because it is truly a must listen. Out of more than 500 interviews I have done, that conversation stands out as one of my favorites. It was so information packed, but also incredibly clear. Dr. Liz has this rare ability to take complex hormonal and biochemical pathways and explain them in a way that actually makes sense. Dr. Elizabeth Bartman is a naturopathic doctor and the chief medical officer of EndoAccess. She has academic training in cellular and molecular biology, along with research experience, which gives her a deeply science-based perspective in integrative medicine. She also holds advanced certifications in herbal medicine, environmental medicine, hormone health, and genetic and genomic nutrition. Her work bridges modern research with the traditional wisdom of natural supplementation, which makes her the perfect person to help us unpack this complicated, fascinating, and very needed conversation. Dr. Liz, welcome back to the show.
Thank you so much. I'm so honored to be here and to discuss this really important topic that is hot on the social media sphere right now.
I know it was so great because I was in search of who can I get to come talk about this? Who's really going to understand? And I'm like, Dr. Liz, she'll know. And I messaged you and you got back to me that day and you're like, well, funny, Karen, I just wrote an entire article about this exact topic. I'm like, yes. So I'm really excited to have you here. In
Awesome. Oh, wonderful.
case
I'm
you couldn't
excited to be
tell.
here. Oh, thank you.
So let's start with the basics because some women I think that are listening probably don't even know if what they have experienced in their cyclical years and even with their HRT that they actually have PMDD. So what is PMDD and how does it differ from PMS?
Absolutely. Very good question. So PMS is our premenstrual syndrome. So really experiencing shifts in mood, emotional lability, crying at commercials that you normally wouldn't cry at, but also some of the physical symptoms like bloating, breast tenderness, even headaches can be classified in this PMS kind of category, this umbrella that's very common. And if you look at just women based on symptoms and this questionnaire and survey throughout the medical sphere, you'll see that about 3 out of 4 women will say yes, they've experienced PMS during their cyclical years for at least a few cycles affecting kind of their mood or their physical body during that kind of week to 2 weeks before their period starts. So this isn't emotional lability, anxiety, or insomnia that's all the time. It's really just with your cycle. What sets PMDD apart? It is really it's much less common. It's about 5 to 8% of women in their cyclical years. And it is significant anxiety, significant depression. It is impacting their activities of daily living, their relationships, their ability to work productively. It is really impacting just how they experience life for 2 weeks out of every cycle. And if you put that into perspective, that comes to about 8.6 years of significant changes to mood and function. And and they say it's like, it's akin to having, a major depressive disorder or generalized anxiety disorder, but it is so specific to your cycle. It's not all the time. But it's really those severe and significant changes in mood, in sleep patterns, in anxiety levels. Women, like, they don't want to leave their bed. They have increased sleep needs, or conversely, they're not sleeping at all, and again, it's cyclical. So
Yeah.
it's almost, I think, worse than, some anxiety forms that are all the time, because that way, at least your body is like, okay, I'm always anxious. This is like, hey, I actually feel normal for 2 weeks out of the month. And then for, 10 to 14 days, I'm in this like totally altered state, this totally disrupted state that's influencing all daily activity and function, in tandem with the physical symptoms, the bloat, the swelling, the water retention, the breast tenderness, the headaches, and again, just all cyclical.
Does it normally come with the physical as well as the mental, or do some women have completely normal, flows, and they're not cramping, they're not getting the breast tenderness, but they get just the severe
Yeah.
mental changes?
Absolutely. It
Okay.
starts, the hallmark for both PMS and PMDD are the mental emotional symptoms. And then they can be in tandem with the physical symptoms as well. But it's the hallmark are really the mood changes.
Yeah, I'm kind of thinking that that is a separate issue. Like if somebody's got the mental issues, but plus they've got the bloating and everything, that's going to be more of a hormonal imbalance rather than PMDD by itself. And if it's just in the head, in the mental space, that it's being affected, that it's not always, it doesn't have to do with the hormone levels, does it?
It does not. It's how your body's responding to the hormones and what physiologic impact those hormones have within the tissues. Yep. So and when I'm going off of the symptoms, I do like to classify, it's like syndrome versus symptoms. So like your mental emotional syndromes and then the physical symptoms. With the DSM-5, so PMDD is classified as a mental emotional disorder defined within the DSM-5, which is where we classify all of our mental and emotional and mood disruptive disorders. So it is classified there. And again, the physical symptoms are included as part of the diagnosis, but the key criteria really are the mental emotional aspects. Yeah, with or
Okay.
without. But yes, I think so. Yeah, it just as you're alluding to, it really is how the body is responding to these key hormones,
Yeah.
versus the hormones being out of balance themselves. It could be a hormonal imbalance as well, but it's really that response
Is there
that we can
any
dive into.
lab markers that you can look at that would help to diagnose somebody with PMDD?
Not a specific lab marker. So long ago, I remember being taught, with PMS in particular, it's an estrogen and progesterone imbalance. And then that would translate to the more significant symptoms of PMDD, probably also an estrogen progesterone imbalance. So let's measure those markers. Well, we've learned, and what you'll see, and yeah, I'm sure people are listening right now and saying, no, it's not, it's not just the estrogen and progesterone, because you can have absolutely normal estrogen and progesterone values. They can look within ideal range for a luteal phase, part of the cycle, when they should be nice and balanced, and yet symptoms are significant, are super severe, and it's not the hormones themselves that are leading to that. Now you can look at metabolites, and metabolites can reveal other metabolic dysfunction, like how is the body actually processing through those hormones.
Yeah.
And sometimes that can point to some key indicators, but again, they're not conclusive. They're not going to be validated as a diagnostic criteria for saying this is likely PMDD. But
Okay.
if you see key indicators that can point to, yeah, that could be the driver for that patient's experience. So the big one there is actually how they're processing progesterone. There's actually 30 different metabolites of progesterone that we secrete as we're processing out that hormone. But the biggie is allopregnanolone. Allopregnanolone is considered a neurosteroid. It can actually cross the blood-brain barrier, and it binds and is what they call an allosteric modulator of GABA receptors. So it binds to a GABA receptor and improves influx of GABA into the synaptic cleft, which is allowing that neuron to basically depolarize and become more relaxed and calm. So it's very, it should be very calming and sedating to the nervous system. Well, allopregnanolone does metabolize into alpha-pregnanediol, which you can measure in urine. You can measure the beta and alpha-pregnanediol metabolites. If someone's pushing heavily into the alpha and is not experiencing the calming influence that we would expect, and instead is experiencing a lot of anxiety, a lot of depressive mood, lethargy, just dysfunction in their daily activities, inability to stay focused, and you're like, oh, this fits like a PMDD presentation, and they're pushing this alpha path, you can suspect that maybe it's the allopregnanolone that's not being utilized correctly by the GABA receptors. And this is actually the primary, in research right now, the primary mechanism of what could be driving PMDD in a lot of women is this maladapted, this kind of altered delta subunit of the GABA receptor that changes how the neurons respond to GABA influx.
And GABA, just so everybody understands, GABA is a neurotransmitter in the brain that is supposed to be calming, anti-anxiety, helps to induce sleep, which is why when women start losing their progesterone, they could get sleep issues. And when you replace that progesterone, they'll say, oh, I sleep so much better now that I've got my progesterone back in. Isn't that right? Yeah.
Yeah. And for most women, you are going to see that more calming effect from the allopregnanolone and the progesterone. But in that small subset of women with PMDD in particular, or neuroinflammation, you get this altered response to that progesterone. So it's not the hormone itself that's the problem, it's how the brain is responding to it.
So when I look at Dutch tests, these are urine metabolite tests for hormones. It's a very popular test. I'm sure everybody's heard of it. We sell it. You guys work very closely with Dutch labs. When I'm looking at the profile and I see that a woman is pushing heavily down the 5-alpha reductase pathway, and then I see that her allopregnanolone pathway through her progesterone is also elevated because of that. Is that always not always, but can that then indicate that, she has really high levels of this, so she could be experiencing PMDD? Or can women have completely normal levels, or even push the opposite side and go down the 5-beta, push down that pathway more so, but yet could still have PMDD?
Absolutely. Yep. It's just one of many patterns. Yep.
That's a practitioner's question. So it probably went over everybody's head, but I'm just curious.
It's a great question though, because there is no definitive. It's not saying, oh, you're pushing the alpha-pregnanediol path on the urine clearance, so therefore you must have PMDD. No, not at all. In fact, women who are pushing more alpha, especially if they're on DHRT and they're pushing alpha, that's a good thing. They're likely increasing their calming and neuroprotective benefits of that progesterone at the cellular level, right, of that hormone. It's just when it's being maladapted. So when you pair it with symptoms, it's okay, so they have significant PMDD symptoms in the luteal phase. They're also pushing the alpha path. Okay, this might be an area where we need to augment response to give support for that client or that patient.
Yeah, I always want to ask more questions. When I see it and it's elevated, then I want to know, are they experiencing PMDD? Because then I can say, you might not be a good candidate for oral progesterone, because then it's going to get that allopregnanolone even higher.
Absolutely. Yeah, it can. And actually using the urinary metabolites when they are on oral BHRT for progesterone replacement can be a good indicator of whether they're using it for the calming effect as well, because some women will just push it heavily beta, even though they're taking the oral bioidentical progesterone. they just, often due to just this aldoketoreductase enzyme pathway upregulation, which can be a sign of liver stress, of other like underlying biliary conjugate concerns. But if they're pushing really heavily towards beta, they actually may not have the calming effect that you would expect from the oral progesterone as well. So another indicator of, outside the PMDD realm, are they getting benefit from oral therapy? If a woman's like, I'm on 200, 300 milligrams, of progesterone and I'm still not sleeping,
Yeah.
and it worked with all my friends and they got great benefit, what's going on? And you look at their urinary clearance and they're pushing the beta, they're just not getting the allopregnanolone response.
Right,
They might need a
right.
different approach to their sleep. But in the same vein, we want to look at cortisol. Cortisol can upregulate neuroinflammation, can alter our stress response and our utilization of GABA as a calming neurotransmitter. We can also look at some of the organic acids that are reflected on on the Dutch panel, like the kynurenolic acid, quinolinic acid. These are both indicators of neuroinflammation. And again, just another tool to say, oh, is this what's driving maybe this altered mood state during the luteal phase?
So root cause could be that the person has underlying neuroinflammation, which is then causing them to have this adverse reaction to the GABA. Is that,
Yeah, just
am I
altered.
saying
It's an
that right?
altered
Yeah.
response.
Yeah. Okay. It's an altered response. Have they found anything else that is the root cause of why this is happening to women, some women?
So many other routes, but I think the big one on social media right now that's getting discussed and then getting like positive treatment response by using that combination of H1 and H2 blockers, which are histamine receptors. There's actually 4 histamine receptors throughout the body, but H1 and H2. H1 is heavily the mast cells and allergy kind of response. H2 is actually in our gut. But we have histamine receptors in our brain. We have histamine receptors in our uterus. We have, they're in our gut. They're everywhere. And when you're taking a combination of, I think the one on social media is Pepcid with Claritin, so an H1 and an H2, one that's an antacid because histamines can make your acid reflux worse. So you're taking this antacid, this Pepcid that's blocking H2, and then you're taking this allergy medication that's blocking the mast cell response and basophil histamine release, that can then create this kind of neurocalming environment that reduces symptoms of PMDD. And the question becomes, well, why?
Yeah.
And so you have to think about histamine in the brain and its role in the brain as a neurotransmitter. Histamine is a neurotransmitter.
Yeah.
It is the first igniting neurotransmitter to stimulate cortisol response in the morning for that cortisol awakening response. So it triggers the hypothalamus to say, hey, we're awake. And this actually came out of research long ago in the 1950s, from Abram Hoffer and like Carl Pfeiffer. And this is like an institute, a subset of kind of more like functional psychiatry called orthomolecular psychiatry. And the role of histamine that it plays in various mental emotional conditions like anxiety, insomnia, schizophrenia, and looking at the role of histamines, pyroluria, so B6 response, copper, zinc balance, and even heavy metals within the body to determine impact to then mental emotional concerns. So that really like sparked. I know, yeah. So yeah.
Back it off here. Okay.
Bring that up.
Okay, so the histamine could be affected by those things like heavy metals, and is that kind of
zinc and copper balance,
and B6. Okay.
Magnesium, vitamin C, of course. Yeah.
And these are deficient levels?
It can be either.
It could be
high, too high or too low. And so with the histamine piece though, so this is really where histamines became this like recognized as a neurotransmitter, recognized within the nervous system response to stress and to anxiety and to mental emotional concerns, was kind of this research that they were spearheading back in the 50s and 60s. But knowing that histamines, they spark that initial wake up response. And in for example, schizophrenic patients, they tend to be low histamine. They don't get that spark. And so they have this like lower drive, or they can be low or high, but there's a subset that are too low and they just are more sedate more in this like zombie effect zone. And so having too little histamine can be a problem. But then you see this other subset where you have increased hallucinations, increased anxiety, increased restlessness and agitation and insomnia. And that's when histamines were too high. And so they saw these two different extremes. And then we can, as functional doctors, kind of pull that out and say, oh, okay, so what's the role of histamine in balance? And how can like slight alterations still maybe not lead us to those extremes, but lead us to those agitated states? And this is where I always, when I talk to patients about, yes, we can use histamine blockers as anxiolytics. In fact, they have a medication called hydroxyzine, which is an H1 blocker, because Benadryl, it's in the same class as Benadryl, can cross the blood-brain barrier, and that's why it makes us sedated and calms us down, right? Because it's blocking those histamine receptors in the hypothalamus, reducing that like stress, anxiety response. So just sedating the nervous system a little bit more. And so, we have a class used for anxiety called hydroxyzine. So then the idea is, well, naturally, can we also support, is that one of the driving factors to the anxiety for PMS, for the anxiety for PMDD? And so I think, over-the-counter solutions like the Pepcid Claritin combo, I always say, yes, if it works, use it cyclically, that's okay, but why is the histamine dysregulated in the first place? And don't sedate too much, because we need that histamine for our awakening response, for neurochemical balance. We need a little stimulation still. Yeah. That was a lot to
and we
run
need
together, but
we need that cortisol, that awakening
yes,
response. I've
exactly.
read some stuff about the importance of making sure that we have that jump of cortisol first thing in the morning, and how it can actually, if you don't have it, it can increase your risk of cardiovascular disease. Have you read that?
It can increase risk for a lot of different things. Yes. So there's actually, this rise, right? So the cortisol awakening response is basically asking the question, do you elevate your cortisol appropriately within a researched target range of, between 50 to 160% gain in the first 30 minutes upon rising, which is like the universal stressor. It's going from a near dead sleep state to being upright and active for the day. So your response to that stress can predict how do you respond to other stressors throughout the day. And we know that the rise in the morning of cortisol does a number of things to our nervous system, to our immune system, to our vascular system. It's basically helping reset the immune system for the day. It helps the thymus reset non-self from self response that was accumulated the day before, kind of gives us a washout. So they've actually shown that people who don't get an appropriate rise in cortisol in the morning can be at greater risk for autoimmune disease, which is an interesting one as well.
Yes.
People who don't get that rise can have more treatment resistance depression. So that rise is helping the hypothalamic response of neurotransmitter development, of serotonin release, of focus, dopamine, norepinephrine. Norepinephrine's our initial stress trigger from the adrenal side, so physical stressors. Are we responding to that correctly? So you can get a lot of information from whether or not you get that rise, and the rise is healthy and important.
Yes, yes. We demonize cortisol, but it's like, no, we want it. We just want it in the right measures throughout the day, and not
at the right times.
Yes, at the right times. So we don't want to squash it, but that's a really key thing to remember, because there's a lot of women hopping on this protocol of H1, H2 blockers. I did test it out on myself, and the one thing I did notice was, wow, did I ever just sleep so well? And I didn't wake up at like the 3, 4 a.m., like wide awake, like I do a lot of the time. And so I was like, oh, is this just because it's sedating me? Like that, but yes, it is. But at the same time, it's squashing histamine, which could be squashing the cortisol, which
could have other downstream impact.
Yes.
Well, and you always have to ask yourself, well, why? If histamines are bad, why would our body make them? Well, it's because they're not bad. We need histamine as a neurotransmitter, as an immune modulator. It is how we, it's our first cell defense to foreign bodies entering into our body. So especially, this is why it's heavily expressed in our nasal passages, in our gut, right? Because it's anything we're inhaling, anything we're consuming. It's basically like little bombs, that can like explode things that we don't want to colonize or cultivate within our body. So pollen and bacteria and viruses, like these things that come in, parasites even, are entering into our bodies, and the histamine's our first defense to attack against that and protect us from non-self damaging our tissues. So we need those histamines. We just don't want them going out of control. Again, it's all about the balance.
Yes. Yeah. So if somebody's PMDD is being driven by histamine, why is it that we only see this then affecting women in the second half of their cycle? Because histamine's always being produced. It doesn't matter where you are in your cycle. So what is the issue then in the second half of the cycle that's making these symptoms appear?
Wonderful question. And that takes us to the role of our sex hormones. So let's talk about estrogen first. Okay. Estrogen is really our primary hormone in the follicular phase of the menstrual cycle. So that's the phase of the cycle. So day 1 is first day of menstrual bleed. And that's when all hormones should be nice and low. You're sloughing off the endometrial tissue from the womb development from the month before, and you're allowing a reset. So this is kind of the time of the cycle when you're going to start to tease out different follicle integrity and choose your chosen follicle for the upcoming cycle. And then that chosen follicle has this layer of cells around it called the granulosa cells. And what should happen is that as that chosen follicle starts to develop, it's growing those cells and expanding and release or generating more and more estrogen to bathe that follicle and make it nice and healthy and mature. Once that follicle reaches mature size, it basically reaches this cap that tells the theca cells and responds to the brain, hey, we're ready to pop, right? And you get this sudden release of the egg that's been nourished inside these cells of estrogen. And you get this cavitation of those cells into what's called the corpus luteum. And that's a transient endocrine tissue that generates heavy amounts, or should generate heavy amounts of progesterone. And that enters us into the luteal phase of the cycle. So we have the follicular phase, developing the follicle, estrogen dominant. In order for the womb to develop, for the egg to, appropriately, for that follicle to rupture, for the right balance of prostaglandins and nutrient influx into the endometrium, which is the next phase we're developing. So we have to develop an egg, and now we have to develop a womb for that egg to implant if we have sperm meeting egg and creating a blastocyst, right? Well, for that to happen, we have to have a little bit of a histamine surge. So histamines help in increasing the neovascularization into the endometrial tissue, balancing out and regulating prostaglandin response that's altering the womb environment, allowing for appropriate implantation were the time to come. And so because we need a little bit of histamine, what does estrogen do? Estrogen says, well, for histamine to circulate more readily to these tissues, I need it to not degrade right now. So it suppresses an enzyme called diamine oxidase. Diamine oxidase is released by our gut, by our liver, by our kidneys, by our lungs. But it is circulating in the bloodstream and helps to break down histamines that are in circulation. So when estrogen needs that histamine to help at ovulation, which is really just for 2 days, right? We get this nice big surge for about 12 to 36 hours, and we want that histamine to be at the ready. So estrogen during that time suppresses diamine oxidase so that we can circulate a little more histamine when we need it to stimulate and support ovulation and then support that immediate endometrial response. Now, what should happen is once you get that release of the follicle, now progesterone should elevate, and progesterone should become the dominant hormone of the luteal phase. Progesterone stabilizes the mast cells so that we don't release excess histamines. So it really is this yin-yang balance of saying, okay, we need a little bit of histamine. We need it circulating a little higher for just this finite window of time, but then we need to balance it out as we're developing and growing the womb into the luteal phase. So what happens if you have too much estrogen and not enough progesterone? Well, now you're increasing the rate of histamines in circulation without balancing the mast cells. And remember, mast cells are basically the carrying vesicles of histamine. So now you don't have that stabilization. Now histamines are elevated, they're not degrading, and now they become a systemic problem. And this is where you get that neuroexcitatory response. You get more anxiety, insomnia, because you're not getting the stability and response from the progesterone to regulate, and you're not getting, and you're not upregulating diamine oxidase because that estrogen is too high. It hasn't come back down appropriately.
But what about progesterone? I thought progesterone was driving PMDD.
So it can.
These women, they don't have, it sounds like they don't have enough progesterone.
It's all different subsets. So it really is person by person. And
Okay.
I would say the blocking of histamines works really well in PMS, because usually PMS is driven by this imbalance of estrogen and progesterone and histamine
Yes.
influx. And that's very common. 3 out of 4 women experience, mild to moderate forms of PMS. With PMDD, these are women that in trials, you give them progesterone, and they say roughly 52% of women with diagnosed confirmed PMDD do not tolerate progesterone well. Right. So in PMDD, it's not necessarily a histamine problem. It's not necessarily a progesterone or a estrogen progesterone imbalance. It's a progesterone metabolite misutilization at that GABA receptor response. Right. So these are two different etiologies for why women could experience anxiety, insomnia, agitation, and mood instability, like mood variabilities in their luteal phase. But they're very different in terms of their reason and influx of response to the nervous system. So that's to say PMDD doesn't necessarily mean histamine imbalance, but PMS could. And it could.
Goodness. Okay. This is
I know,
there's
this is where the
so
body
many
is so
pieces. I know. It's like, well, and I just know, like, it's so funny because over my years of coaching, I saw that some women with PMDD or severe PMS would react so well to progesterone. You'd say, okay, let's put some progesterone in, and it would be like a miracle, and they'd feel so amazing. And then other women, you give it to them and it completely exacerbates all of their symptoms. And so I just always knew, and I would say this to them, I'm like, sounds like you have PMDD, and we'll try progesterone, but just so you know, this could go either way.
Exactly.
But I didn't know
and
why.
it really is nearly 50-50 split, right? Because it's about like 48% are going to do roughly, this was like one study of 800 women, and 52% with diagnosed confirmed PMDD. So severe, significant changes to mood during that luteal phase. And 52% did not tolerate progesterone at all, whereas 48% did pretty well with progesterone, right? And so you have this camp, and that's always why I say to women who are struggling with PMDD, I'm like, we could try it, but you'll know within a cycle whether or not it's going to work for you. And if it doesn't work for you, it's not going to work. Like, that's not the angle we need to push. Because again, it's not the progesterone itself that's the problem. And it's not maybe even the histamines that are the problem. It's the fact that the GABA receptors are altered and therefore not responding to the allopregnanolone correctly. And I mean, we could get into the weeds with all the other pieces that go into this, right? Because let's talk about, progesterone itself. For allopregnanolone to work, it's not increasing GABA, and it's not increasing the receptors. It's just binding to the receptor in order to increase influx. So think of, GABA receptors, they really look like little flowers, like a tulip. And they have these little petals around it. And just like, a bee would come and sit and pollinate, that's what the progesterone is kind of doing. The allopregnanolone is coming and sitting to help then the GABA, help that receptor open up to allow GABA to come in to that synaptic cleft, into that neuron.
Okay. So it's almost like it's making it more sensitive to the GABA that's already in the system. Right. It's like,
right.
We're going to open the door here for you. Come on in. Mm-hmm. Okay.
Exactly. Okay. It's like it's like turning I don't want to say like turning a faucet on because it's not really turning GABA up. The GABA is there, it's being stored in vesicles, but it's allowing the inflow, it's allowing it to enter into those synaptic clefts at a more ready rate. It's saying, enter in, come on in, instead of, being blocked or inhibited or impaired, or instead of, so this is the other piece of the puzzle, right? So we need the receptor. We need the petals of the receptor to all be in the right form. That delta subunit, that's one of the petals, right? It's one of the pieces of the subunit that's it's not gonna allow that influx in the same way. Right? It's altered enough that the allopregnanolone can no longer bind, or is altered in its binding state, augmenting then the amount of GABA that can come in. Well, what is GABA made from? GABA is made from glutamate. Right?
Which
And we
is so
have
weird because it feels like glutamate should not be able to make a calming hormone because glutamate is excitatory.
It is excitatory. Well, it's the two sides, right? Our
Yeah.
body is full of yin and yang.
Yes.
It's
Yeah.
like we
Yeah.
need the excitatory, but then we need to put the brakes on, and we need it to also then convert into this calming version of
Okay.
itself.
And what makes
So it's
glutamate?
like,
Let's keep going up that chain.
well, so glutamate is coming from our diet. It's coming
Okay.
from like mostly from foods. It is going to be converted through a decarboxylase enzyme, GAD. And if you don't have, and we know there's actually polymorphisms that can reduce the amount of glutamate conversion you have to GABA, that can be a predictor of concern for increased anxiety
Yeah.
or increased like neuroexcitatory response versus calming response. And again, this is really where metabolomics becomes really fascinating because you can layer, right? We have these polymorphisms, and remember, so single nucleotide polymorphisms are just a single base pair change within a gene that alters the enzyme being made. These are not mutations, they are adaptations that help with our phenotypic diversity and help in key scenarios for us to thrive. So it's like our ancestors needed these variables or these variants in order to survive and thrive in their environments. Now, they can become maladapted in our current environments because we don't have the same stressors we once did. But I always like to say our genomics are a tool of risk assessment, but not absolute risk. Right?
Yeah. So basically, genes. We all have our set of genes, but a lot of them will be turned on, turned off through environmental triggers.
Yes. And then
Just to kind
they're
of dummy
gene
it down.
expressed. Yeah. Well, and then the actual enzymes made can be different depending on your ancestry and what your ancestors needed for survival. And so again, we can look at those, we can look at your risk, and then we can layer that with how you're expressing, like inflammatory and oxidative stressors, hormonal response. We can look at your gut because the gut is regulating a lot of our neurotransmitters, our inflammation, our histamine balance, right? So it's playing a role there as well. And then we can take all of that and look at organic acid output and see in real time what is our expression in our environment at this point in time, right? So you can look at those pro-inflammatory end products. I would argue sex hormones and their metabolites also reveal kind of a metabolomic response because it's impacted by our genes
Yes.
and our environment and our gut to reveal our phenotypic response in real time.
Okay.
And that can be further information to help us understand where we want to treat or support. But there's multiple layers. So we have to look at, are they even making GABA? Are they keeping too much in the glutamate form and pushing NMDA receptor response?
And what
This
would
can be
that
seen
look
in a lot
like
of
as far as symptoms if somebody was doing that?
significant anxiety, insomnia, agitation, but more chronic. These are people
Right.
that are experiencing it
All the
throughout
time.
the month, not just during the luteal phase. Yeah.
Yeah. And so that could mean that they've got lots of glutamate, but that glutamate isn't converting into enough GABA. Is that right?
Exactly. Yep.
Okay.
And that enzyme, GAD, directly dependent on a form of B6 called P5P, which is pyridoxine 5-phosphate. So that's directly dependent. Whenever we talk about like supporting GABA, we think we need optimal B6 levels. We need to reduce neuroinflammation. We need to have hormone balance. We need to have histamine balance because these are all things that would exacerbate an already stressed system. But it's all about layers and how it expresses for that individual. So there's multiple avenues of why women might experience these really big changes to mood.
And there's some women I've seen too that have both, like they have a known histamine issue. So they've got histamine intolerance all the time, but plus they have progesterone sensitivity and PMDD.
Yes,
And so it's like both of the like two different things then are coming at that. Could be the
absolutely.
histamine thing, and which is going to make everything's going to get worse in the luteal phase, but at the same time they can't be piling on progesterone because they have that sensitivity. So they're kind of
Exactly.
at a loss as far as like what do they do?
Well, and in those cases, so you always want to look at not just the estrogen absolute values, but how they're being metabolized.
Okay.
Because remember, we have diamine oxidase, which is helping to break down histamines in circulation. We also have histamine N methyltransferase. That's intracellular histamine metabolism. As its name implies, it's a methyl dependent detox pathway. So, what does estrogen do? Not only is it impairing diamine oxidase, right, expression when it's high, when it elevates. So it rises up, it reduces diamine oxidase at that time so that we can have histamine at the right time in our cycle to support ovulation, to support implantation, if that were to happen, vascular flow to the endometrium. But estrogens also then have to be metabolized. And there are steps to taking estrogen, which is a fat based hormone, right, and converting it into water. And so we call these the phase 1, phase 2, and phase 3 clearance of all of our sex hormones, but of estrogen, we're going to talk here. So the intermediate, the first step is hydroxylating that estrogen. And when it gets hydroxylated, it forms 3 different intermediates, but 2 of them are called catechol estrogens. So the 2-hydroxy and the 4-hydroxy forms of estrone and estradiol are catechol estrogens, and they require catecholamine O-methyltransferase for phase 2 clearance. So I think of phase 1, sweep it up into little piles. Now we have to put it into a garbage bag. Phase 2 is a methyl garbage bag, just like intracellular histamines require a methyl garbage bag. So they're both dependent on SAMe as the primary methyl donor, just different enzymes donating. But if we're depleting our SAMe pool because we have all of this estrogen, that's going to further impact intracellular histamines, worsening histamine intolerance in the luteal phase. So you can look at your clearance and you can look at your rate of methyl garbage bags. And you can say, well, maybe we need to support methylation. Maybe we need to get this up, while also potentially reducing any histamine burden or estrogen burden that could be putting stress on the histamine pathways. So that's another, when you're seeing this intolerance to progesterone and you're seeing this histamine kind of driving worsening of those PMS symptoms, anxiety, insomnia, agitation, and they can't take progesterone. They're just, you have likely that subunit alteration that's just not going to respond to progesterone the way we would expect for calming the nervous system. Well, then look at methylation and support breakdown of the histamines if needed by reducing estrogen burden and improving methylation if that's a slow pathway. If that all connects.
Yeah, I'm gonna have to re-listen to this and take notes. But this is what I wanted. Like I wanted the deeper dive on this because I don't find too many practitioners really understand all the different mechanisms of action that are going on with this. And, and we're seeing this now with this protocol where some women are being really, really helped by taking the H1, H2, and then other women, they don't notice anything. And so then it's like, okay, well, what could that tell us then? Would that tell us then that histamine's not driving the PMDD?
Very likely. Yeah, if they're
Yeah.
not getting a response from it, then it's probably not a histamine problem.
Mm-hmm.
Yeah.
Yeah.
It may more likely be the altered delta subunit of the GABA receptor, or the other piece of the puzzle. So let's add even more to it. So there's also the sustainability of progesterone. So
Oh.
maybe you get this nice rise, but it drops really sharply right before, like those 7 days before the menstrual period starts, you get a rapid decline in progesterone. that can also be a trigger for PMDD in some women. So
Right.
we
The
have multiple,
fluctuation or
the
the
significant
deficiency.
fluctuations. Hmm.
Is it both? Like they're reacting to the drop, but also the low levels.
Yes, both.
Okay.
Yeah,
Yeah.
so it's really it's the sudden loss
Right.
of that stabilizing hormone. So they don't have sustainability to progesterone for the full luteal phase, and instead they get a shortened or a dropped
Why?
or a rapid decline
Why
in that
would they get a
progesterone.
sudden drop? Why aren't they sustaining it?
Well, and that that really comes down to the question of the corpus luteum,
Yeah.
because the corpus luteum. So a few things about the corpus luteum. So it is a really fatty tissue rich, mitochondrial dense tissue. And when you think about progesterone synthesis, so progesterone requires cholesterol, it requires vitamin A, it requires reduced oxidative stress and appropriate mitochondrial function, so appropriate mitochondrial cell respiration and redox balance. Um, this actually takes me down a whole different rabbit hole that we can get into. But really, it's when you don't have sustainability to progesterone, the question becomes what is going on with the building blocks and the mitochondrial function of the corpus luteum. And so it's really helping sustain the mitochondrial response, which is a direct response to oxidative burden within the tissues. The higher your oxidative stress at the origin of cell development, so in the follicular phase. So we have all of these primordial follicles that have yet to go into their antral follicle stage, right? So we have all of these eggs in our ovaries, and they're going to get exposed to oxidative burden every cycle, every day. And they've been with us, just to put this into perspective. So women in our ovaries have all of our eggs present as cells, as little itty bitty primordial cells in our ovaries in the second trimester of our development in our mother's womb. And so it is exposed to these oxidative stressors, not just in our lifetime, but also for a portion of our time while we were in utero and developing. So they've been with us for a long time. They have a lot of oxidative response and stress. And that's why we decline in our eggs so rapidly over our years. And by, in our 40s to our 50s, we're at kind of our basement of around, a few thousand eggs left.
Yeah.
And all of those are going to be like just the longer they're with us, the more oxidative burden they have, the lower or more poor the progesterone output will be in that luteal
Quality
phase.
goes down.
Yeah. Yes.
Yes.
Exactly.
Okay.
Yeah.
Okay. So the quality goes down. So then we maybe just like we'll ovulate and we'll produce some progesterone, but it's not enough. And it's not enough
It's
to
just not.
sustain to the end of the cycle.
Exactly. And we can see this in younger women too, but
Yeah.
we tend to see exacerbations. So women who have been diagnosed with PMDD, they tend to have exacerbations in their early 20s when hormones are really starting to like figure themselves out and surge, and we get a lot more dysregulation before we start to normalize and
Yeah.
get into a more of a balanced pattern. And then in our perimenopausal years, you can start to see that exacerbation shift again because once again, the progesterone decline and the hormone response is starting to get shifted quite a bit. We don't have that same stability.
Yeah. Yeah. Which makes it so hard because then in perimenopause, they get suddenly worsening PMDD and they get really bad perimenopausal symptoms because their body is so reactive to the deficiency of hormones and just the fluctuations of these hormones, which is then impacting the histamine. So it's just the perfect storm to have
It's
a
a perfect
absolutely
storm.
horrible perimenopause. Ah,
Yes.
so awful.
Well, and I want to pull us back to the gut too, because then the gut's
Yeah.
playing a role, right? Because it's going to help partially if we have balanced, a balanced, healthy, optimal microbiome. Uh, I shouldn't say optimal, like best for us in a standard American diet culture, like as good as we're going to have.
Yes.
Because there are optimal for other cultures. But yes. So when you have a good microbiome foundation and a good terrain, that microbiome is playing a role in regulating our immune system, in regulating histamine response, in balancing hormone metabolism and clearance, in giving us nutrients required like B6 and B12 and vitamin K. And like it's giving us nutrients required for optimal methylation and optimal detox. It really works in our favor. But when our microbiome is in an imbalanced state, when we have dysbiosis, we're pushing to more opportunistic bacteria, suddenly that shifts. We're not generating the same support and balance to our nervous system and our neurotransmitters and our immune balance. We're pushing cytokines. We're pushing immune dysregulation. We may be further altering histamine response and histamine imbalance and mast cell sensitivity and instability. So mast cell degranulation can be increased with dysbiosis. So it's really, we really have to look at our environment, at our like nutrition and inflammation, but also at our hormone balance, but then also at our microbiome and our gut, because it all really does play a role in how we then express phenotypically and function and feel in our existence in our bodies.
Yeah. And if we were to kind of go layer by layer for somebody that is being driven by histamine issues and they've got the sensitivity to progesterone, you would probably go, okay, let's try to reduce that histamine load first by working on the gut. Like, is that what you do in your practice when it comes to somebody with histamine? Are you going straight to the gut first if someone's got histamine intolerance?
I am. Yes,
You
I'm
are.
treating the gut and calming the nervous system. So anti-inflammatories and GI support. But
Okay.
with the gut, it's not just about the microbiome. It's also about how we're processing fats and fibers. And so I also want to support the liver.
Okay. So liver and gut. Probiotics with histamine, is that an issue? Like, do they not go together?
It can be. It depends on the
Yeah.
probiotic.
I know. So I'm just thinking of that product that our mutual friend Krishnan with Just Thrive probiotics. And I interviewed him and I interviewed the other woman, Tina. So fascinating. And their probiotic has B6 in it, I do believe. And they do talk about how much it helps with mental health, their probiotic.
Yes. So certain lactobacillus strains have been shown to. So it's Lactobacillus plantarum is the one I'm most familiar with. Microbiome is not like all the different family and species are not my forte. I just know the big ones that play a role
Yeah.
like in our mood and our hormones.
Yes.
But I know Lactobacillus plantarum can help with GABA receptor expression. So that's the other piece that I didn't
Okay.
go back to. So we have to
Oh,
have
yes.
GABA
Okay.
present, and we
Okay.
also have to have GABA receptors expressing for allopregnanolone to bind to improve neurosynaptic response and calming influence.
Okay.
So we support GABA by improving GAD, that enzyme that's using B6 as a cofactor to convert glutamate into GABA. So now we're increasing GABA storage. We're increasing GABA receptor expression through the use of vagal tone support, but also this Lactobacillus plantarum can help increase the expression of GABA receptors in the prefrontal cortex. So that was pretty cool. But it's through that superhighway of the vagus nerve and that response. So it's the GABA receptors were independent of other intervention. This was the interesting piece. It was like you either had the lactobacillus species or you didn't. And that was the direct predictor of the GABA receptor expression in the prefrontal cortex. So kind of
Meaning
fascinating there.
like so basically like somebody could take that lactobacillus and it would help with that GABA receptor sensitivity, PMDD, but then other people, if they had it already, then you knew that it wasn't going to influence it.
Right. Or if they are just generating the wrong isoform, right, of that delta subunit of the GABA receptor, then, well, increasing the receptors doesn't help if they are genetically just not generating the right receptor,
Right.
right? So
Okay.
that would be a piece of that puzzle.
So we
But I think that's where the B6 can be helpful. because it
Right.
would play a role in the GABA generation in tandem with the microbiome, the correct, distribution of different bacteria in a probiotic that's supporting, GABA and serotonin and reducing inflammation,
Right.
possibly stabilizing
So
histamines.
we want to improve the GABA react like the receptor. We want the receptors to react well to the GABA stimulation, basically, right? So we want glutamate to get to GABA, and then GABA to be able to get into these receptors appropriately. And so we do want to improve that, because I just think it kind of messes with your head a little bit, because if PMDD is caused by get this sensitivity to the GABA, it's like, well, why are we wanting to improve GABA then? Wouldn't that make it
No,
worse?
in
But
these
it's
cases, it would be like
not.
PMS. Right. It's
Okay.
modulating. You want to modulate the GABA response, reduce neuroinflammation. And then again, in that subset of the population that has the altered subunit, supporting the progesterone side of the equation, probably not the way we want to go. Right? It's more modulating the nervous system, reducing inflammation, and improving methylation if you think there's a histamine driver there.
Yeah. Yeah. Okay. I think I'm going to wrap my head around
Yeah, I know there's so many, and that's where, and again, I see on social media, I was, watching this H1, H2 blocker phenomenon coming out. And I was like,
Yes.
yeah, totally. Like, this is something that we would actually use a lot in like urgent care when patients would come in with severe, poison oak flares. We would do an H1, H2 blocker. Just to calm down, plus a prednisone, just to calm down the immune system and the histamine response. So it is something that gets used in tandem frequently for other conditions as well, and can be used. It's the reminder that it has to be used safely and appropriately. And you don't want to use it all the time, because we need little surges in histamine to appropriately, get a correct ovulatory response, and to get the correct, trigger to our brain to get our cortisol awakening response to surge optimally in the morning, and to regulate our immune system. So it's not about absolute suppression, it's about balance.
Yeah. Yeah.
And then, I would see, this H1, H2 discussion, and then I would see, this other angle from functional medicine doctors saying, well, if it's a histamine problem, then support it with progesterone. And as we've discussed here in length, that's not always the solution, because it's not
It
always an issue with
exacerbates.
progesterone,
Yeah.
right? It's an issue with how the brain is responding to the progesterone.
Yeah. And I hate it
So,
because they're villainizing estrogen yet again.
yes,
Right. And it's
exactly.
like it's estrogen causing this histamine. Drives histamine up. But the way you've explained it is like, hello, we need this. Like, this is all very important.
It just has to be in balance,
It has to be
right?
in
And that's where we
balance.
look at what is the absolute value of the estrogen, what is its rate of methylation, how is it being processed correctly, is the gut involved in possibly recirculation of that estrogen, do we need to work on gut for that balance and support? But really, I mean, estrogen, yeah, you're right, it does get villainized a lot, and
It
I
really
love
does.
estrogen.
Same. It's my favorite.
It's my
Couldn't
favorite
live
hormone.
without it.
No.
What do you think is happening then for the women who don't have a history of PMDD, but yet they have progesterone sensitivity, mostly to the oral progesterone, which I see more and more and more. And maybe it's because I am a practitioner that actually talks about it and deals with it. And we help patients that are suffering with progesterone sensitivity. We know what to do and how to treat it. So maybe that's why I see so much of it. Because I was talking to Dr. Lindsay Berkson. I had an interview with her recently, and she was like, I never see this. And I'm like, well, probably because you guys aren't talking about it. And so people aren't coming to you to have that fixed, or to have an alternative treatment plan. So I just think that I just see more and more women coming out of the woodwork saying, yeah, I can't take oral progesterone. I take it and I get severely depressed, or I get super angry, or like when I take oral progesterone, if I take it too much, I get really snappy, and then I go into severe weepiness and depression, and I just cry and cry and cry, and the darkness is awful. But I don't have
So,
PMDD.
no. Yes. So again, it's the allopregnanolone, right? Is kind of the and again, it's just one of 30 metabolites of progesterone. But when you take progesterone oral, you are hitting the gut and the liver heavily, right? You only actually absorb systemically at best about 10 to 20% of the oral or anything oral taken and then absorbed, right? But the bulk, so say for example, you're taking 100 milligrams of oral progesterone, typical
Standard.
starting
Yep.
dose, and it hits the gut. It goes through first pass metabolism. So now all of that 100 milligrams has to be broken down. Only about 10, maybe 20 milligrams will get absorbed systemically, but the rest is going through the liver and getting processed into these various metabolites, not necessarily circulating as active progesterone. And it's that allopregnanolone, so the liver converts a lot of that oral progesterone into allopregnanolone, more than you would generate naturally on your own from the corpus luteum. So you're getting a lot more allopregnanolone exposure just by taking it oral because it's hitting the liver. And that's one of its metabolites that heavily forms from hitting the liver, right? So now we have a lot more allopregnanolone. That's the one that crosses the blood-brain barrier. Now, there's a few things that could be happening. Number one, because progesterone, it sedates, it calms, but too much sedation, too much calming, not enough balance of serotonin and dopamine response, and now you get more of this depressed nervous system, right? You're going to get into this kind of low, this fatigue, this sedation. If you're not balancing it with serotonin, our feel-good kind of focus hormone, our dopamine, our focus, pleasure, reward hormone, neurotransmitter rather. Like if we're not getting that even balance, you could experience a lot more sedation and then depression and lethargy and, weepiness because of the balance piece. And when you look at what estrogen supports serotonin and dopamine response in the brain. Progesterone is GABA. Right? And so you look at that neurotransmitter balance, it's like, okay, well, we definitely want that. We don't want too much allopregnanolone, and we want enough estrogen to also support our neurotransmitter response and our BDNF response in the brain and our tryptophan hydroxylase response, so that conversion of tryptophan into our serotonin and further into melatonin.
Yes.
And so I think there can be a piece of that where it's just too much allopregnanolone because of liver conversion. But I think there's also, the reason it's becoming, because this wasn't always, I feel like it is more of a thing recently.
Yeah.
And I think that there's a lot more neuroinflammation, be it because of exposure to like just increased environmental toxins, the nanoplastic accumulation that we're seeing on the rise, whatever it may be. I think, heavy metals, arsenic. I see more cadmium coming up on tests these days. I see a lot more glyphosate on tests. I think these are all contributing to neuroinflammation, which would further alter how you're responding to that allopregnanolone.
Yeah.
And an interesting thing, and this is more of an aside, I would say this is more theoretical, but is worth pondering.
Yeah.
And it's definitely something I keep my eye on in the research. I think with this kind of recent surge in the literature on the delta subunit alteration of the GABA alpha receptors, I'm like, okay, that's fascinating, on PMDD front. But there's this other kind of theory being floated. So theory number 4.
Yes.
That when your nervous system, so if your nervous system is dysregulated or inflamed or stressed, and then you push this allopregnanolone calming response, that is at odds. And so all of a sudden the receptors are thinking, there's this theory out there that you are programming your calming response to be triggered in a high stress state. And that pushes more of the neuroinflammatory or stress response. Because instead of it saying, oh, you need to calm, it's saying, oh, we have all this calming hormone, but we are stressed. Therefore, calming must mean stressed. And so you get this dysregulated response to the receptor and what's being allowed into the synaptic cleft, and then what's being allowed to regulate the nervous system.
Ooh, that makes sense to me.
I thought it was really fascinating. I'm like,
yeah,
that's what I'm keeping an eye on. I I don't know
There's,
how they can test it, but it is a theory being floated.
I
Yeah.
mean, and you were just talking about the vagus nerve piece too, um, and how that has so much to do with histamine. And I've heard this a lot recently that you absolutely have to consider your nervous system and what it's doing and the condition that it's in if you do have histamine intolerance.
Absolutely.
Right? Which is so, like, I think for a lot of people that they don't understand that. They don't understand, well, what do you mean? Like, I'm stressed out. Everybody's stressed out. Yeah, I've got trauma. Everybody's got trauma. Why would that affect histamine?
And a big piece of it, so I think it is how it's altering, like how stress alters the microbiome, how stress alters our cortisol response, how that, like, we start to degranulate and become more sensitive to the release of histamines when we're under higher amounts of stress, when we're in that sympathetic fight or flight, because again, histamines are the protection. And if we are in fight or flight mode and our instinct is to say we need to run from danger, well, part of that danger response is I also need to heal if I get injured. If I get bit by a bear, I'm going to be exposed to a lot of pathogens. I need to be able to have a first line defense to release histamines to attack those pathogens while my immune system starts to upregulate and like further go towards whatever the point of injury is and scrub out the pathogen and heal up the tissue. Unfortunately, so all of this like domino effect of stress is playing a role on then how our mitochondria are functioning, how our immune system is regulating. We increase our basophils and our mast cells so that we're going to be having more exposure and expression of potential histamine release as needed. We are going to have greater, vascular weepiness. We start to like allow things to, we get swollen, right? We get puffy
Yeah.
because we need to be able to get fluids into the tissues to flush out the pathogens. We need to be able to focus. So we're going to have dysregulated neurotransmitter response. We're going to push NMDA, which is that glutamate, more neuroexcitatory response because we have to focus. We have to like be able to quickly get away from danger and assess
Right.
our situation. Well, but what happens if we're actually not running from a bear and we're not burning off all of this energy and we're not resetting our nervous system? Instead, we're just working on work deadlines and, adding more to our plate with family obligations and personal obligations and financial and, just like it's never ending. The body doesn't realize that there's a difference in running from a bear or working on a deadline. The same domino is happening. We're just not burning it off. And so all of a sudden, we are in this state of this basically like hyper-inflamed, neuroinflamed, and kind of weepy vascular response that's going to put us in a histamine dominant position.
Yeah. Yeah. That makes sense. And when I'll link to these two episodes, interviews that I did earlier this year to my list for my listeners, which is one on the vagus nerve and then the one I did with Huron, which is about the gut. But he goes into the vagus nerve and the effects of the vagus nerve on gut health. And that connects the nervous system piece to the gut because we have the vagus nerve running through our gut. And so if you are in that fight or flight state and you're stuck in sympathetic, then yeah, guess what? It's going to start to affect your gut microbiome, which
It
then
absolutely does.
you're not
And
going
it
to be able to deal with
increases.
histamine.
Exactly. And more importantly, and I don't know if Karan went into this as well, but I know it's another hot topic that he's well versed in. And if you get him back on your show, you should ask him about endotoxemia, because that's the other element is you get this dysbiosis, you get a leaky gut. Everything becomes leaky. The vascular system becomes leaky. We're getting lymphatic leakiness and our gut becomes leaky under these high stress states, meaning that it's not a tightly enclosed system, which it's supposed to be. And instead you're getting this movement of bacteria and basically these like altered end products of bacterial metabolism are now, instead of getting eliminated through the gut, are now entering into the bloodstream. And one of them, or a big category, are called lipopolysaccharides, and these are endotoxins. And these can create even greater inflammation to the nervous system, greater inflammation to the brain, to the liver, to the nerves. Yeah, so it's just like this vicious cycle, and it does. Like I think the gut and the nervous system are really the two key players that are regulating the immune response and helping the brain communicate to tissues like our ovaries to respond to hormonal synthesis. And if we're in this dysregulated state and we still have follicular drive, right, we're still in our cycling age, the amount of hormone that we're producing throughout the month can start to become dysregulated because, again, in that fight or flight state, we are not in a state where our body feels we are okay to have a baby, right? And so
Yeah.
we downregulate our hormones, and that just adds even more fuel to this inflammatory fire.
Yeah.
We become more estrogen out of balance because we're not releasing a follicle, we're not creating that corpus luteum all the time successfully, or the amount of progesterone being made because of the increased oxidative stress goes down. So you're getting this surge and drop instead of a nice steady progesterone throughout the month. So really, it's like it's all connected.
Yes. Oof, we're just screwed. I think that's what it comes down to. It's like, oh my God. So many things, right? So let's talk about kind of two places where women can go to get help with if they're experiencing both histamine, but also the women that are experiencing the PMDD, progesterone sensitivity. What should these women be doing first? When it comes to histamine, I know that there's DAO supplements. So should women be taking that to help break down their histamine? I hear no. I hear that it actually doesn't work that well.
It doesn't work that well, and there's a negative feedback response where if
Oh,
your
okay.
body is receiving a bunch of DAO, it's going to say, "Oh, we don't need to make our own as much anymore," and so you can actually like stop generating your own over time. Anecdotally, I think there was one study that said this is a risk, and so I've just kind of always been a little cautious with
Yeah,
it. So,
same.
uh, yeah, yeah, but you know, again, it's about regulating the hormone response and really balancing the gut health and the methylation that's supporting. And the other thing to remember with histamines, so you break down histamine, either extracellular or intracellular, both become these aldehyde intermediates. So you also have to have acetaldehyde dehydrogenase working optimally. And this is where alcohol becomes a problem, right? And so if you have women that are struggling with histamine imbalance or estrogen dominance, or progesterone is kind of that paradoxical progesterone response is occurring, like you've got to cut out the alcohol. The alcohol is a
Yeah.
piece of the puzzle that is going to deplete that aldehyde dehydrogenase enzyme family or it's just depleting the reserve. And so you won't have as much to then break down the intermediate of the histamine being metabolized through either extra or intracellular response. Intracellular histamine also gets further broken down, so it gets methylated by the histamine N methyltransferase enzyme, and then it further gets broken into the aldehyde intermediate via the MAOA and MAOB enzymes, which are the same enzymes degrading serotonin. So kind of an interesting connection there, and estrogens play a role on MAOA expression as well. So optimizing estrogen, we don't want too little, we also don't want too much. But I always like to pull in that connection as well of the alcohol piece. Like if this is a concern, the alcohol needs to come off the table if that's something
Yes.
that's
Yeah. Yeah.
being consumed. Because even moderate intake of alcohol can disrupt clearance of histamines and will also be disrupting some of our hormone balance and can put us more into an estrogen dominant state and definitely increases neuroinflammation and alters the metabolites of estrogen, including our methyl metabolism, because it's depleting all of our methyl groups. And anyway, it's another one that just cascades.
Okay.
So alcohol piece, and then really it's about looking at the patient's unique phenotypic response. And I think you can get a lot of that review by looking at urinary hormone clearance,
Yeah.
because you can see what are they favoring in terms of their different intermediates of estrogen, their 5-alpha versus beta path, their cortisol, those organic acids, looking at the neuroinflammatory end products, so kynurenate and quinolinate. 8-OHDG is another great one for oxidative stress. And then looking at their methyl index and seeing if they're methylating optimally, because estrogen's a regular player in the female and even in the male body. And their rates of methylation can be an indicator of, cellular methylation throughout the body, not just what's happening to the estrogen direct.
Yeah.
But
And
I
what
think those are
about like
good places to look.
histamine diet? What do you
Yeah. So
I've never found that that's worked. My whole family has histamine issues. My sisters, me, my sisters, my mom, my dad, all have terrible histamine problems.
yeah, so it's always working upstream, right? So it's always working with where does histamine land and how can we optimize that? So focusing on the livers, focusing on the aldehyde dehydrogenase pathways, working on even antioxidant support. So free radical scavengers like vitamin C can be great, and acetylcysteine, glutathione support, all important cofactors. But then you can also look. So the diets, yeah, the
Just don't.
diet premise, the premise there is all about like reduce the foods that contain histidine
Histamine.
and histamine, and then also take out the foods that liberate, that are mast cell destabilizers.
Yeah. Which
Right,
then
so
you're
those are like
left
the
with nothing.
fermented foods. You're left with nothing, right? I always say it's like the best foods. It's the best summer meal. It's like it's your strawberry goat cheese almond walnut salad on
Right?
spinach with balsamic vinegar. That's like those are all of them.
And bacon bits.
Yeah, and yeah, the nitrites. Yep.
Yeah.
Yeah, exactly. And then like certain medications are also considered more histamine liberators as well. And yeah, I think it's really restrictive. And I don't
Yeah.
know if it's where you need to, like if you're in an acute flare and you just need to like reset,
Yeah.
possibly like a short course of just cutting out those foods might help. But really, again, it's treating the microbiome, it's treating the nervous system, and it's treating the liver and making sure that you're reducing oxidative stress.
Yeah. Yeah. I think those are the three top, aren't they? Like let's target those first and get those going and then see where you're
And
at.
you can use mast cell stabilizers, absolutely. I always caution against like quercetin, it's a great mast cell stabilizer. It gets a lot of anti-aging research, like for senescent cell response and like improving cell senescence, so like reducing senile cells. um, but quercetin does inhibit methyl activity. It's a catechol, and it requires methyl donors for metabolism, and it can put further stress on methylation. So if someone's a poor methylator, be cautious with quercetin. That's my caveat. But using things, natural substances that are mast cell stabilizing can sometimes be helpful as well. But I think it's really about just reducing the oxidative burden and supporting antioxidant status. Start there.
Which I have like a genetic snip so that I was fully red, like on the bar for oxidation. Like I have terrible oxidation and I need extra antioxidants in my system.
Absolutely. And so
Okay.
supporting the pathways that generate antioxidants for you. So NRF2, right? NRF2 is the intracellular enzyme that is held in the cytoplasm of pretty much every cell in the body. And it's kept bound to what's called the keep protein. But it gets liberated and can enter into the nucleus and increase expression of glutathione synthesis, catalase, SOD, which is that superoxide dismutase. So catalase protects our DNA, repairs our DNA. Glutathione is our master antioxidant. Just to put this into perspective, we think about like vitamin C as a free radical scab, as an antioxidant as well, right? And it's about a 1-to-1. So if you have a free radical, it can help neutralize at about a 1-to-1 ratio. This would be the same with like vitamin E with our antioxidant group of nutrients like resveratrol and vitamin E. But glutathione is 1,000+to 1. So it's like a vacuum. It's going out and just vacuuming up all of our free radicals, all of our unbound floating oxygen species that can damage our cells and damage our DNA. So I like upregulating glutathione. NRF2 can do that. It upregulates kind of a cell wall protective
Is Nerf 2 a
mechanism
supplement?
called. No, it's an enzyme, and it
Okay.
is upregulated by a few things.
Okay.
The biggie is sulforaphane. That's the supplement. And specifically glucoraphanin plus myrosinase. So these two in tandem form sulforaphane within the cell versus taking direct sulforaphane, which hits the gut and then denatures. So you want to take the glucoraphanin with the myrosinase. That seems to show the best bioavailability of intracellular sulforaphane and NRF2 response. Green tea. Green tea improves methylation, is a free radical scavenger and potent antioxidant, and upregulates NRF2. That's another nice one. Pomegranate. Pomegranate is a great antioxidant. It upregulates an enzyme called PON1 that helps kind of scrub up glyphosates and a lot of our pesticides. So
What about curcuminoids?
Curcumin's wonderful. Yep.
Okay.
It's more on the anti-inflammatory cell modulating response. So it's going to downregulate TNF alpha, IL-6, IL-1 response. So it calms down that inflammatory activity. Yeah.
Okay. And acetylcysteine, because a lot of people can't take straight glutathione. And in my practice, I have found that NAC seems to work a lot better for people than glutathione. Like a lot of people don't feel well when they take it, or they just don't feel it at all.
Well, and here's the issue. Yeah, I also would agree. Don't give straight up glutathione.
Okay,
give the NRF2 promoters to upregulate glutathione production at the cellular level.
Okay.
But there's these enzymes called glutathione S transferase, sulfur transferase enzymes, the GST, and then you have like the theta, pi, mu, and omega variants, and they're expressed in different tissues throughout the body. But it's a fair number. When you do genetic reports, you can look for these. They get reported on a lot. And there's both copy number variants, meaning you either don't even make that family of enzyme, or you do, or there's also polymorphisms that just render it a little less effective. But what these guys do is they're fairly common. It's actually the most the GSTM deletion is one of the most common deletions in the human genome. So, and it just means that you're not going to transfer the glutathione to the free radicals appropriately. Like you can't transfer it to where it needs to go. And so if you don't have these enzymes working, and a lot of us don't, then giving straight glutathione just isn't going to be the solution, because it has nothing to bind to get delivered to where it needs to go.
Right.
The truck isn't available to take it to where it needs to be. Or really, it's like a person passing it on, right? It's like putting the bow on the package.
Okay.
You don't have your person putting the bow on the package. And so I think helping your own cellular mechanisms upregulate the response to glutathione and generate your own glutathione so that it's at the intracellular level where it needs to be to do its job is the better approach. And so glutathione is a complex amino acid. It's made of cysteine, glutamine, and glycine. Again, glutamine, most common amino acid in our diet. We don't need more of it. We don't want to push anything further on the glutamine side. But glycine plus cysteine, and that's the N-acetylcysteine form, is the most common form delivered. That combo can be awesome for supporting glutathione as well. Because now you're getting the building blocks.
And glycine.
And glycine together.
Oh, and I love those. I'm naturally very drawn to both of those. Glycine is so great to relax my nervous system. It helps with sleep.
It helps with GABA response. It helps, it's calming to the nervous system. It also supports folate independent SAMe generation. So it decreases stress to the methyl cycle. There's a lot of, it's got a lot of great
It's
benefits.
really good for something with heavy metals too, or getting rid of glyphosate, maybe? Not a heavy metal.
Because
maybe
it's
it was
going to be
glyphosate.
It's supporting glutathione, right?
Right.
Because
so
it's one of the 3 aminos to make glutathione.
It's going to help you detox, right? Okay. Oh, so fascinating. Okay. That's great.
So yes, I love N-acetylcysteine, and I love N-acetylcysteine, especially when it's in tandem with glycine, and then in tandem with NRF2 promoters like green tea and sulforaphane. And remember, sulforaphane comes from broccoli sprouts, so that's
So, which is great, to metabolize estrogen, get it out of the system. So kind of that little combo, that little stack could be really great for people that are dealing with definite histamine problems and mast cell problems. Okay.
Absolutely. And I do love nettle. I'm going to throw that one in there too. I think quercetin gets all the rage for mast cell stability. And again, I'm like, okay, I get it, but it also has some problems.
I can't take it. I can't tolerate it.
Yeah, a lot of people can't. And that's where I love nettle. Nettle comes in to save the day. And, stinging nettle. You think, oh, it triggers the histamine response. Well, yeah, it does. But the root can be a mast cell stabilizer. So there's a lot of constituents within the root and the leaf, but they really do stabilize and modulate the immune system and can stabilize those mast cells and support the liver. More liver
Okay.
support.
Now, does Endo Access, so Endo Access is a supplement line for like a professional supplement line that has to do with for hormones, basically. And this is Dr. Liz is the medical director of this company. Do you guys have formulations with these ingredients in them specifically for people with histamine and bad cell?
So it wouldn't be specifically for histamine, but it would be
Okay.
for the same enzyme support that would benefit histamine intolerance.
Okay.
But it would also be supporting catechol response, cell protection, DNA repair. Right, so our formulations are really based on multiple pathways that can be out of balance to result in hormone dysfunction.
Okay.
And so Formula 12, that is our, so Formula 1, 2, Formula 12 is our potent NRF2 promoter. So it has the sulforaphane in the glucoraphanin form, plus the myrosinase, plus a little N-acetylcysteine, plus it has the nettle, plus a little pomegranate. And because we're upregulating NQO1, which is our cell wall protection, it also has CoQ10, which supports that process as well. And it's going to support our electron transport chain in the mitochondria for mitochondrial cell respiration and ATP generation. So that's a really nice combo. I love that one.
Yeah.
It's
I'll
what I
link
take
to
every
that
day.
one. Okay.
Yes.
Okay. Super.
And then because we're also talking, PMDD and that allopregnanolone
Yep.
potentially in this small subset of women being a problem. And
Yes.
again, I want to put it out there that allopregnanolone for the majority of women is very neurocalming and very
Yes.
supportive, but there are groups of women that just cannot tolerate it. And what we found is that 5-alpha reductase, it's actually a family of enzymes, but they're involved in the metabolism of DHEA and testosterone, as well as progesterone and cortisol. And they metabolize into the active intermediates. So when you see that higher alpha pregnanediol metabolite and it's connected to a PMDD presentation and a woman who just cannot tolerate progesterone and their progesterone might look optimal, you're like, oh, you've got great progesterone, but it's pushing this alpha pathway and they're struggling with symptoms of PMDD or severe PMS. Inhibiting 5-alpha reductase can improve symptoms. And again, this is really in our clinical observations. But when you look at the research coming out on that altered delta subunit for the GABA alpha receptors, that's their approach as well. They're just using medications that inhibit that allopregnanolone conversion and binding to the GABA receptor. So
That be dutasteride?
yeah, it's one of them.
Yeah. Yeah. Because that's what's, yeah, this sometimes we'll recommend for women that have really bad PMDDs, dutasteride, which for those listening,
Exactly.
that is a medication that's commonly given to men that are balding or women that are having a lot of androgenic side effects to their testosterone replacement therapy because it blocks or slows down that 5-alpha reductase activity.
Exactly. Yep. And
Yeah.
so we can do that naturally with herbs like saw palmetto and herbs like nettle. Nettle also inhibits 5-alpha reductase or downregulates expression of 5-alpha reductase. You can do that with vitamin C to stabilize and support. You can use reishi mushroom, downregulates expression of 5-alpha, but is also very neurologically calming. It supports other aspects of it supports serotonin response and it supports more of an optimal like BDNF acetylcholine response in the brain. So different side of kind of modulating the neurochemistry. And then we also have what else is in that guy? Well, I think the reishi's are the big one. The reishi, the saw palmetto, and the nettle. That in tandem, plus some of our nutrients and antioxidants, not only will protect against androgenic symptoms that we can see worsening like prostate issues in men or acne and hair loss, kind of that male pattern baldness hair loss that women can experience as well. So these are our natural 5-alpha inhibitors. But they can also support mood and they can also support that progesterone metabolism. So using this formula 6,
It's okay.
to reduce, if alpha is favored in their progesterone clearance and they struggle with PMDD, using formula 6 can help modulate their response by decreasing the allopregnanolone conversion. So you're pushing into the other metabolites that the body needs of progesterone, like more on the beta metabolite side, that are getting used within the endometrium to protect the endometrial response, but you're downregulating that neuroactive intermediate. And we do see good benefit
You
with
do.
significant, like severe PMS symptoms, and again with our subset of PMDD,
Yeah.
of which I'm going to put this out there. I'm going to be totally candid. We've only had a subset of 5 women who have been diagnosed with PMDD, have shown alpha preference, and have taken formula 6. But of those 5, it's a 5 of 5 getting positive response. So that's pretty
Oh,
huge.
that's
Yeah.
huge. I'm the total offside here because I'm just thinking about these labs that I just looked at the other day with a patient who has severe PMDD, and she's 52 going into menopause. Her estradiol is like, she's still cycling, but it's starting to get a little bit, just not, she's not missing periods, but I think they're coming close. Oh no, they're coming late. So she's definitely starting to get into menopause. Anyways, severe PMDD. She's tried very low doses of topical progesterone, low doses of estradiol, and she has a severe mood reaction to both. Anyways, I was looking at her labs and she had over range for the first time. I've been working with her for a while. For the first time, over range testosterone and DHEA. And I was like, oh, well, that's interesting. And I understand that, just for the listeners too, when we start to go through perimenopause and menopause, you could actually start producing more testosterone because we make estradiol from the testosterone in the ovaries. So your body will turn up testosterone production because it's wanting to make more estrogen. So women can actually get kind of testosterone dominant during perimenopause. And so I kind of thought, oh, maybe that's why. But I'm thinking now, if she's turned that up, and that's now that 5-alpha reductase activity is also getting turned up, could that be why she's having such severe PMDD right now? Do
It
you see
could
what
be.
the puzzle?
I see the puzzle, and I'm wondering, I'm going to reframe it because I don't think the answer is that she's higher in androgens and pushing 5 alpha. The question becomes, why is she pushing 5 alpha? And 5 alpha upregulation occurs because of inflammatory cytokines, namely IL-6, can drive up expression, as well as TNF alpha. And then we also see, the number one promoter of our SRD 5A1 and 2 enzymes, which are the 5-alpha reductase primary drivers of testosterone into DHT into 5-alpha androstenediol. Same with DHEA. Is insulin, high circulating insulins. And I think when we get into our perimenopausal years, FSH becomes dysregulated, and it's a whole cacophony of like dysfunction. But what I see so often is that in perimenopausal years, any like decently controlled but present brewing metabolic dysfunction becomes suddenly exposed because we've lost the estrogen that was kind of supporting the enzyme response of so many different metabolic pathways. Like estrogen
Yes.
regulates PPAR A and PPARG expression, which is oxidized fats and utilization of fats and sugars and insulin response. It's supporting our choline synthesis. It's supporting our vascular. It plays a role in almost every single tissue in our bodies in terms of regulating metabolic function and blood sugar control. And when we lose that estrogen, like it's becoming so dysregulated, we suddenly unmask all of this kind of underlying dysfunction that becomes a lot more obvious. And then to add insult to injury, we become androgen dominant because we're pushing. So there's 2 layers of cells around eggs, and those cells are the theca layer and the granulosa layer. And the theca layer is where we initiate hormone synthesis. And those cells remain as long as there's some follicles around. We're going to have those thecus cells. What happens though is that there's not the granulosa development as much because the egg quality just is, it's declining. We don't have the amount there anymore. So we don't have that response and growth of the granulosa cells. But FSH is like, knock, knock, knock. Come on, let's drive up aromatase. Let's get all of that, because estrogen is made from testosterone, from androstenedione. And so we're pushing like more and more hormone upstream in the thecus cells. So more and more androstenedione and testosterone and DHEA, even up to mild degrees. But it's not aromatizing, right? Because those granulosa cells are becoming resistant because we don't have the eggs in the same like reserve and health and quality that we once did. And so instead of aromatizing, you get this higher and higher FSH. And that can be a mark, right, of peri, and then is our gauge of, are they going into their postmenopausal years? And it gets really high right into postmenopause. You can see it in the 80s, even up into the hundreds. But FSH isn't just trying to knock on the ovary to make estrogen. It's also, in increased amounts, it acts on any aromatase response, which is very active in adipose. And so we get this upregulated leptin resistance, insulin resistance from this higher FSH response on adipose aromatization, and this kind of dysfunctional insulin response within the adipose to try and get whatever little bit of estrogen we can from any other cell that can contribute.
Yeah.
And we know FSH also can impact like bone turnover. And so we really want to monitor FSH. I don't think it gets monitored enough.
I agree.
Right. And I think that, when we're seeing this like higher androgen preference in perimenopause, and then this worsening of PMDD, I almost wonder if it's, again, not to keep reiterating, but if it's this like increased neuroinflammation driven by these this higher insulin response and higher circulating insulins, because we've lost the protection of estrogen. And we have this dysregulated FSH knocking on adipose now, making us more insulin resistant, and then driving up 5-alpha reductase preference, which is then impacting not just the androgens, but also progesterone and cortisol.
Right. Makes sense to me.
To circle that around.
Oh no, that's what I want though. I like put the puzzle together. Okay, so when it comes to then the person with the progesterone, sensitivity, PMDD, what is like our top stacks for that one then? B6.
So for progesterone sensitive PMDD presentations, I do like that like modulation of allopregnanolone. So the 5-alpha reductase inhibition. Make sure blood sugars are being regulated. Vitamin B6 is wonderful because in the P5P form, right? Because that's the form that the neurons use for conversion of glutamine into GABA. Glutamate into GABA. All the different subsets. And then I think it really is. It's working on metabolic health, on gut health, and on reducing neuroinflammation however you want to do so. And I think, the glycine can be really helpful. I think, again, the Lactobacillus plantarum or other probiotic support that's working on that vagus response. Managing cortisol, being really careful about we don't want too much, but we also don't want too little. We need that nice optimal cortisol awakening response occurring in the morning. So getting full spectrum light, getting outdoors, movement, just gentle restorative movements. Again, the diet that, worked for women when they were cycling is not going to work for them any longer because their metabolic profile has changed because of their altered hormone status. So really trying to dial in their appropriate new macro needs, reducing your refined sugars, really supporting protein, optimal protein consumption. We know that goes up a bit, but optimizing their ratios, making sure they're getting adequate fiber. And then, reducing alcohol, because that often becomes, you can tolerate it in your 20s and your 30s, but once you hit your 40s and your 50s,
no.
It's like,
all the fun is gone now, ladies. Don't just kidding.
It is. No.
Now it's for the better.
It is for the better. Yes.
What about
so that's
medications? I was just interviewing a fascinating woman Dr. Greenwald. I don't know if you know her, but anyways, she is talking a lot. We didn't actually talk about this in the interview. We talked about it off air because it wasn't about birth control. But she told me about these new birth control pills that she has been prescribing to her perimenopausal and menopausal patients, and asking them, do you want to ovulate? Because ovulation is bringing so much grief to women with PMDD. And then their PMS is so severe that she's been using one called Zoli or Noma, which has nomagestrol acetate and 17-beta estradiol in it. I don't know have you heard about these birth controls?
Yes. So I think there are,
And
so
Duvi
that
was
is,
the other one.
they, so estetrol, it's E4. It's like this weird subset of estrogen. I think is what's being used in which will actually metabolize. You'll see it in urinary profiles, which is really
Yeah, the
fascinating as well.
Duvi one is contained. I looked it up before this. The Duvi contained equine estrogens, so old school hormone replacement therapy. So it's got, which isn't bioidentical. So it's got equine estrogens with, it wasn't a progestin, but it was something that protected the uterus. And then the Noma or the Zoli has actually bioidentical 17 beta estradiol in it in conjunction with nomagestrol acetate, which is like spironolactone, she said.
I think there is, yeah. So you're getting that kind of like modulation to 5-alpha reductase, and
Yeah.
yep.
Yeah. She's like, it helps with women not losing their hair. She thinks it's so great because it shuts down ovulation and helps with PMS. But in my eyes, I'm like, oh, I just can't be convinced of this because I'm very kind of anti-birth control in the sense of like birth control for perimenopause and menopause. I just think, why not use bioidentical because they're the safest and have the safest profile and have the least effect on all the other systems, right? Taking oral estrogen, we know, causes lots of downstream side effects. And so I just can't be convinced of this yet, but I also don't know anything about it. So
I
your
think
opinion.
so. So you have to factor in what is the impact to quality of life. Because I would
Yeah.
agree, I'm not a huge fan of birth control, except for in very specific scenarios like PMDD, severe PMDD, where being able to just
Yeah.
keep them at steady state, low levels of hormone so that they're not getting the fluctuations and the allopregnanolone response and the histamine, like they're keeping everything basically offline, right? They're just taking this synthetic hormone that modulates their own response to tell the brain, hey, it's okay. Like we're in steady state now. We don't need to ovulate. We don't need to,
Yeah.
we can take the brakes off that for a while. And that really can give some women a
So
lot of
much
reprieve.
relief. Mm-hmm.
And if that's, if it's really their quality of life, and then and as we've been talking, it's like, well, but the bioidenticals might not help them. They might actually make
No, it
them
might make it
worse because
worse.
they're not
Yeah.
responding to them, right? And so it's in these small subsets, it's like, no, there really is a time and a place. It just has to be done correctly. And then you have to look at the other factors that can happen when you're on synthetic hormone. And so we look at mineral depletion, we look at the gut microbiome alterations, and we support those.
Yeah. Yeah.
So that if it's giving them reprieve and it's giving them final relief and they can actually live life again and thrive, and then all we need to do is just replace the vitamins and support the gut that are going to be altered because of the medication they're taking, I think it's worth it.
I think
I
so
mean, I
too.
do, yeah.
I do.
And
I do.
especially in peri and postmenopausal women, because then I don't have to worry. I'm not worried as much about getting their HPO axis back online when they want to get pregnant. Like
Yeah.
I have bigger
Yeah.
qualm when it's like a 20-year-old who's trying to regulate their cycle. And again, in the right scenario, it can be game changing and life altering in
Yeah.
a positive way. But in younger women, trying to get them off, these are strong birth controls. So
Yeah.
trying to get them off of it and trying to get their endocrine system naturally back on and regulated can be a lot harder. And so in younger
Very
women, I'm a
challenging.
little more
Yeah.
cautious.
Yeah.
But in peri and postmenopausal women, we're not worried about their reproductive function in 5-10 years.
No, and if it could give somebody that kind of literally life-saving relief for some of them, even just relief so that you can live your life, you would probably only have to take them for that period of perimenopausal years, because once you stop ovulating and your ovaries are like, we're done, forget about it, then they could probably come off of them because they're not going to be having those swings anymore. They don't have any hormones.
Exactly.
So for a
Yep.
brief period
And
of time.
and I will say this too, because I will talk to some providers where they're like, well, well, okay, so first off, like the idea of first do no harm,
Yeah.
right? And so I think in a lot of people's minds, especially in functional medicine, first do no harm means don't bring in a medication. But I would argue that
Yeah.
the harm is that they are going through these phases every month where their mood is beyond their control, and it is
Yeah.
augmenting and altering their life so significantly that I would say doing no harm means getting that under control and balanced. And if that means medication, then that's first do no harm.
Yes, I agree.
Yeah.
100%.
And I will say this too, I will talk to colleagues where they're like, well, okay, that's all well and good, but those are really strong birth controls. Like, why don't we use a more gentle option? And I will say this about more gentle options, like a progestin only, or, and it's like, well, that may or may not work. And that actually may have more side effect.
Yeah.
Like, these were developed to provide that suppression that really does give the relief to the nervous system from the alternating and fluctuations of these hormones in a way that can provide that relief versus like I would say trying lower doses or like altered forms or like weaker versions may actually do more harm because it's not going to give them the relief they need. And now you're just like trial and erroring until you probably end up on the same birth control eventually anyway.
Yeah, exactly.
Anyway. Yeah.
No,
So those are my thoughts there.
Yeah, I agree. I think that there's a time and a place for sure. And if it can give somebody their quality of life back, then that's everything, it's everything. What about SSRIs? I know that there's been a lot of research done, and they actually show really good results with women with PMDD taking an SSRI just in the second half of their cycle. And that's showing that it actually works well, because a lot of the research on SSRIs actually showed that they're not very effective for general depression.
Exactly. Yeah. And they're meant for short-term use.
Yeah.
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 No, yeah, I would say SSRIs, again, you have to use the right form, but it's that estrogen, it's the serotonin balance. So it's giving back the serotonin response that can often get dysregulated when you have this altered kind of GABA menergic push that's not getting the right response during that luteal phase.
Yeah. Okay.
And I think they can really be a game changer too. And again, you just have to, if it's harm reduction, right? It's an analysis of harm reduction. So if this is going to work, it's an intervention that they tolerate. Now we just have to make sure that we know, like with SSRIs, we know that they can reduce efficacy of folate and B12 metabolism, and they tend to work better longer term on lower doses when we can bring back those B vitamins. We know that there can be an altered gut response as well from SSRIs. And so like just supporting the gut, supporting the liver, supporting B vitamin and remineralization when they're on, and like magnesium's the big one there. But like just bringing back the right cofactors that we know the medications can impact or deplete.
Yep.
Or put stress on, and then, optimize their success so that the patient can get the best response at the lowest dose for as long as they need.
Yeah. Amazing. Okay, well, Liz, we did another 2 hours. We did that last time too. It was like, boom, 2 hours was done. I'm like, oh my God, I can't believe we just talked for 2 hours. But
it's so easy. You're so easy
I
to talk
appreciate
to.
it. And I really appreciate your time that you spend with me. So thank you very much. I look forward to obviously having you back again.
Absolutely. I would be more than honored.
Yeah.
And
Okay,
yes.
good. I'm going to put links to these formulas that we're talking about in the show notes. I'm going to put the link to our last conversation, because we actually, in our first conversation, we did go into the hormone sensitivity thing a lot in that one as well, but in a different angle. And so I think it would be great for everybody to go listen to that too, if they're wanting more information about the stuff that we've talked about here today. But if you're suffering with PMDD and you are listening to this, or you've had progesterone sensitivity and you're having a tough time finding something that's going to work, write these little suggestions down, these little stacks down that Dr. Liz has shared with us here today, because that would be where to start. And I think really don't ignore the nervous system piece. I feel like that has so much to do with what's going on in our brains with this hormone sensitivity. Is we need to be paying attention to our nervous system. All of these other things, yeah, great, but don't forget about the nervous system, because those are everyone wants to just take the supplement, take the medication, call it a day, because that's easiest. It's not easy working on trauma. It's not easy working on nervous system. It takes work.
It's the long game for sure. Yeah. But it's worth it. It's needed. Yes.
Okay. Any last words for our audience about today's discussion that we did not talk about?
I think, when we talk about hormones and how they respond in our brain, and we're going through these conditions that, again, PMS, so common, PMDD, not as common, but very debilitating, and both kind of a reflection of how hormones can be very different within their response in the nervous system, right? And how they can play a different role depending on expression of your GABA receptors, to how your gut and your nervous system are regulated. I think I really want to emphasize that, yes, it is very complex, and we are all so bio individual in many ways. So it's finding what's going to work best for you. And it could be a combination of multiple etiologies that we discussed today. It could just be one that's really your driving force, but exploring these different routes and just knowing that, what works for one person, just because it's a fad on Instagram, may not be the best option for you, or it may be, and so having that patience and having that, understanding that you're not alone in this, and that there are solutions. It's just finding the right solution for you.
Yeah. Yeah. And finding people that can help you, because it's not good to do this on your own. As you could hear here today, very complex here. Very complex.
Hard to navigate.
Yeah.
It's good to have someone else just to have that perspective, to keep everything in perspective for you as you're swimming in the deep waters trying to figure it out. Yeah.
And the guidance, the step-by-step guidance, so that you're not just frozen with overwhelm going, no, this is way too much. I can't even begin to go down this road. Because I know that that's what a lot of women think. And so I just want them to hear that, no, just take it then do one step at a time, one thing at a time. Bring in B6, bring in some glycine. Just, start there, then slowly start adding. Because a lot of these women too, they feel so terrible that it's so hard for them to start deep diving into the root cause and what could be causing it, and getting, all the things in place that could help them. It's too much, because their system they're not in a place mentally to be able to handle it and get better, which is terrible. And I feel sorry for everybody that's going through this. Oh,
it's a hard place. Yeah. It's a lot to navigate, but you're not alone in navigating it. There are resources available, and yes, I think reaching out is the first step, and then just taking one piece at a time.
Yeah. I'm going to take today's transcript, and I'm going to deep dive into all the different things that you talked about, so that I can get a real grasp on it. And then I'm going to write a series of blog posts about this, so that people can chunk it down, and so that people can read and take it little bit by little bit. So, and then that'll help me to get it stuck in my brain too.
And I'm always happy to go over any pieces that might be confusing, or do a part 2 or a part 3, however that we always happy to, always available.
Okay. Thank you so much, Dr. Liz. You're amazing. I appreciate you so much. Thanks for coming on the show.
Well, thank you, Karen. Always a pleasure.